3, 2, live.
How does this feel? 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 We're really excited, Raina and I, to host this show today. But before we do that, let's find out who's behind the white coat.
It's me! I finally got the show! I'm so excited that I have the show. After all these weeks, all these headaches, you two did such a great job. Thank you.
Well, we're not done hosting.
You're hosting the show?
Yeah, we're hosting.
Wait a second.
What
Yeah,
are you doing? Did you guys start the show?
Of course, no.
Did you just try to start the show?
No.
Did they start the show?
He tried to start
You started the show.
It's their show.
Ready.
Ladies, sir.
Jesus. Okay. Hi, ladies.
Hi.
Oh, I love how you did that. Do that again. Hi, ladies.
Hi.
Oh, wow. I can get used to that.
Don't get used to it. Don't get used to it.
Well, here we are.
Yeah. New location.
New location.
I hear you're going to be on the road, Doc. You're going to D.C., New York in March, and now you're traveling throughout L.A.
Oh, yeah, we're
It's
gonna
like
do-
being international.
I am. The
Yeah.
International Man of Mystery.
Uh-oh. That's awful.
So, welcome to episode 3 of Behind the White Coat.
Episode 3. I cannot believe it hasn't been canceled
What's the
yet.
name of today's show?
How does this feel?
How does it
How
feel?
does this feel? How does this feel?
You missed the
Oh, that
opening.
feels great.
All right.
But anyway, this is how to look and feel your best in 2017. And on the show tonight, we've got 3 powerhouse physicians. My man from Manhattan Beach Vein and Laser Center, Dr. Mark Rayman, is in the house.
All right.
From Pro Health Interventional in Beverly Hills, peripheral vascular disease specialist, Dr. Amiel Moshfegh, here in the house.
In the house.
Finally, anesthesiologist and wellness doctor, the lovely Natacha Telusca, is also
All right.
here. We have a great show for you tonight, but before we start, once again, our very special musical guest, the lovely Starlee.
Take it away, Star.
So this is called Back When You Started It All. Take 2.
Back when you started it all, do you remember all you used to do? And back when you found them all the friends who supported
Dr. Boo. I don't think you can sing like that, man.
You
Can
haven't even heard me.
Karaoke later?
Yeah, a little karaoke later.
Wow.
All right, here we go. Welcome back.
We're back. First, what we didn't even mention earlier is while you're taking your extended bathroom break, a squatty potty.
Oh yeah, this thing is
By the way,
great.
what is this? This isn't like everyone has the plastic squatty potty, which by the way is amazing. We love our sponsor. But you have like the deluxe squatty potty. Like, what's the deal with this one? Talk to us about it.
Well, this is the teak version of the squatty potty.
Okay.
And man, I never felt like so much of a king, like a king.
Yeah, that's why you were late for the show.
It's hard to leave the bathroom with this thing around. I mean, it just feels great.
It's good.
So how does it feel?
How does it feel? Well,
how does it feel not to have one?
I adopted a squatty potty life. It's been good, man. So it's already a great show. Love the people who've been on it, and I know you have a special guest today. You as an interventional radiologist. That's how I met you, and before you became this big TV star.
Yeah.
You big timed us. Who has a bigger ego, a doctor or a TV star?
It's hard to tell.
The fans can let us know that.
Yeah,
but I know today's a lot about interventional radiology, so I guess that's where we go to.
That's right. These two guests have been, my good friends for a really long time. We were all in the hospital setting together, and they are off doing their own kind of thing.
Yeah.
I am off kind of doing this show. They're off opening their own practices. So one of my mentors before, he's been really in the vein world from way back in the beginning, has developed a huge vein practice, opened up his practice in Manhattan Beach. Here with us, the medical director and doctor of Manhattan Beach Vein and Laser Center, Dr. Mark Rayman. All right. And joining him, also interventional radiologist, now hails in Beverly Hills, peripheral vascular disease specialist, ladies and gentlemen. Who's behind the white coat? Dr. Amiel Moshfegh! Alright. Well, welcome both of you guys. I am surprised I was able to drag these guys out on a Tuesday evening. But I'm an interventional radiologist. The two of them are interventional radiologists. What is interventional radiology, Mark, for the people out there?
It's a very good question. I have no idea. Actually, interventional radiology is the branch of medicine where we do a myriad of minimally invasive procedures under imaging guidance.
Yeah, so it's a lot of minimally invasive work.
Under guidance.
Under guidance, yeah. So a lot of what I do now is interventional oncology. That's you entering blood vessels to be able to deliver chemotherapy directly to the tumor, or being able to place a small probe or electrode into a tumor and burning and freezing it. But Mark, you're treating veins.
Right, yes. I took a branch of interventional radiology that is the most superficial and meaningless branch, but to me it's everything, because people often care more about what they look like than what's going on the inside. So what I do is I get rid of people's cosmetic deficiencies, whether it's their veins or their body fat or their hair.
Oh wow, we'll talk about that in a second. What's up?
I'm coming to you.
Well, I see it works on me.
I have a follow-up question with you anyway, Mark. So now that you already said it's superficial, it takes my questions away. But I know a lot of people, they have some criticism of a lot of areas of medicine, especially the superficial. But are there actual health implications to sort of fixing the superficial that you found during the procedure?
There actually are health implications. So people can have pain, aching, cramping, burning, pain, leg heaviness, fatigue. They can develop clots in their legs. They can have leg swelling. It can impact their lives. And on a separate note, how people feel about themselves means everything. If you're self-conscious about putting on clothes and going out and doing the things that you want to do, meeting that great guy or great gal, and if you could get rid of those blemishes, it means a lot to them mentally. So it's both physical and mental.
Think of how you would feel after you got yours treated.
That's good.
Now, listen, so Amiel, he does veins and he does a lot of superficial cosmetic work. I do oncology.
I'm sorry, can you just call it vein? Like V-A-I-N?
Vein.
Yeah.
Vein.
Yeah, it's just been sitting there. You called it superficial 9 times.
Okay,
Sorry, I'm the producer.
All right.
If you have a pun hanging that...
There's a comedian.
Okay.
Yeah, there's a comedian.
Sorry.
You're getting heckled by a comedian. That's it.
So Amiel, you treat arteries And you're treating fibroids. How do radiologists start treating arteries and fibroids?
So, arteries. So there's two sets of blood vessels, right? You have arteries which deliver the oxygenated blood. The veins drain it. Mark specializes in the veins. The arteries, the issues with the arteries is we get a lot of patients that have multiple comorbidities. They have diabetes, they have high blood pressure, they have high cholesterol, they have all that. They have a smoking history, and inevitably the arteries will start to kind of scar down, they'll form plaque, and you're not getting enough blood flow down there. So the patients I'm seeing will usually have pretty severe cramping, they're not able to walk. How did interventional radiologists start doing this? They started doing it by, Mark can tell me more, he's been in the field longer, but, but from what I understand is they started diagnosing it. They started doing angiograms, and then once they started diagnosing it, there was a guy named Charles Dotter.
Yeah.
Yeah, and he invented the angioplasty balloon, did the first angioplasty, opened up the vessels that were small, and that really restored the blood flow, got them up and walking and feeling better again.
That's great. So just to give you guys a brief history, the father of interventional radiology is actually Dr. Charles Dotter. He was a...
the father's a daughter?
There we go.
Father's daughter.
There you go.
Do we?
No,
we
we don't
don't
have
need.
that.
Okay, we don't have
Just
that.
flush the toilet.
So he was a diagnostic angiographer. So he took pictures of blood vessels. But he said that if with a diagnostic catheter, with imagination, you could actually use it as a surgical tool. And all of a sudden, the field of interventional radiology started to blossom. He was able to go into blood vessels and open and close them. That's how we were able to go into blood vessels and put chemotherapy in there. So we're going to start to talk a little bit more specifics about each individual subspecialty within interventional radiology, starting with veins. So Mark, I see you guys have a poster here. What are different type of venous issues that can cause symptoms in people with vein problems?
So believe it or not, varicose and spider veins are extraordinarily common. About 50% of women over the age of 50 will have some sort of a vein problem if they're like, it could be a little tiny spider vein like this, or it could progress to a big bulging vein like this called a varicose vein. So the varicose veins they look like a bag of worms almost underneath the skin. And the spider veins, they can occur anywhere on the legs, they can occur on the face. And they're very easily fixed. People used to think that, oh, they're fearful that it's going to hurt or that they're going to have a cosmetic deficiency afterwards, but the truth is there is a wealth of new procedures that have been developed that are specifically geared towards interventional radiology because we are trained in our specialty to use ultrasound as a guide to pass a catheter into somebody's body and basically treat the vein. We basically can cook the vein by passing it up the leg and we close the vein. And so it's a very simple, elegant procedure. And then we have these little tools that make tiny, tiny little nicks that take the veins out. So you can see, you can't even see any evidence that anything was done. And we're very proud of what we can do in our field, and it's fun.
So many different specialists treat these veins, but I mean, as an interventional radiologist, really having the tools and understanding ultrasound and knowing the imaging really makes the interventional radiologist the expert in treating veins. Is that correct?
That is true. But there are many other specialties who do vein work. I just feel like we do it better.
Right. So
sorry about that, all you vascular surgeons.
We did bring an example of an ultrasound and what this ultrasound exam looks like. So Mark, go ahead and demonstrate. We're gonna
Go to Mark.
Excellent. Well, I happen to have brought my probe today for this event.
It's a good thing that you don't leave home without your probe.
I always take my probe with me.
Okay. All right, and we have the lovely Rena here.
Yay.
Oh, I'm gonna go up here, Mark.
Yes,
Yeah,
I was
this is
about
right.
to.
Okay, perfect.
I was about to expose my probe.
Oh, please.
And
It's not the kind of show.
Oh.
here it is, right here.
Oh, the probe is not as large as I thought it would be.
Didn't say you could touch it.
Consent.
Okay,
yeah.
so now we're gonna put this down and
Here, why don't you put
pull
that
this
here?
chair up right here,
All right.
like that. And this is our beautiful patient who probably has no vein problem whatsoever, but she's beautiful, so that's why she's here today. And we're just on the other end. All right, so we are going to take we're going to close the study right now.
Do you want to get
There
it?
we go. So what you're going to do is you're going to turn your leg out just a hair like that.
Do most of your patients get their ultrasound exams done in high heels?
They, no.
This is the only patients he has. If only his wife was in the room during this conversation.
Most of my patients don't look like Rena, but I will tell you that some of them do. And you can have a very, very beautiful person have just one cut. Oh my God, you've got a big vein. Okay, so if you take a look right here on this screen, you will see this big black hole here, and that is a vein. It's a pretty, what, you're poo-pooing the vein?
That's a good size vein.
That's a good looking vein.
Oh,
Okay.
God.
I'm just fighting for whose vein is bigger than his vein.
Now, what I'm going to do, what we do is to detect whether she has a problem is I'm going to squeeze her calf. Is that okay? Can I squeeze your calf?
Yeah, you can squeeze
Okay.
it.
And when I squeeze her calf, it's going to push the blood. Do you want to hold her up? Yeah.
We'll all hold on to you. That's good. Yeah.
Okay. Now, when I squeeze, let's see what happens. If it's black or blue, it's normal. But if it goes blue and then red, then Rena has an issue. Did you see that blue? That's a normal vein. So it can go red for just a brief second. I'll give it another squeeze here now. That's a normal vein.
Great.
So Rena, you're okay. You're going to be all right.
Yes.
Well, I haven't looked at everything. But in general,
That's great.
we usually work our way all the way up to the groin, but we're not going to do that today because your leg looks normal. So in any case, this vein right here is called the great saphenous vein, and that's what it looks like transversely or in cross section. If we turn the probe lengthwise, you can see that it's a long channel like that. And it is the vein that most commonly goes bad, and that's where we always start our ultrasound exam. And the ultrasound exam is the key to diagnosing venous insufficiency, which you don't have. Congratulations.
Thank
All
you.
right. Thank you, Rena.
Thank you, Rena.
Welcome. Thank you.
I feel like I saw Rena.
That was a great
show.
demonstration.
So I have the common man question, which hopefully the docs can help me. So I remember back in the day when ultrasound was for pregnant women, right? Like that's how most of us see ultrasound. And I know that's really changed a lot, right? Where ultrasound's getting used a lot more. So will you guys kind of walk us through, I don't know where the MRI, the X-ray, all that stuff starts from, where it goes to, and where ultrasound came in. So what do you use for each type of thing, and then why do you use what you use?
Well, I think as far as Mark and I are concerned, we use ultrasound a lot for vascular purposes. He uses it to diagnose venous disease, and he also uses it during the procedure. Right? He could speak more to that. He's using it to guide him throughout the whole procedure. I use it to diagnose arterial disease, like you saw when you put it in longitudinal. You can pretty much map out the entire artery from groin to toe, find where exactly the problem is. And I also use it to access the artery. And there's many more applications than that. Carotid arteries, you can go from the neck down to where you use ultrasound. I don't know how much it's changed over the years, but we're using it a lot for
So a lot of
interventional radiology.
That's true.
Yeah.
Now, if you were looking at the pictures, a lot of you guys, saw the black and the gray screen, and how does anybody make heads or tails out of it?
Yeah.
Radiologists get trained for years to understand those images there. So it's really important to have that imaging knowledge to do this work very well. So Mark, excellent demonstration there. Now, different ways to treat veins. Can you talk about some of the traditional treatments? And I heard there's a new treatment now where you can glue the vein and there's no inflammation. So let's talk about some of those traditional treatments, and let's talk about venous seal.
Okay, so let's just talk about what causes varicose veins. Well, people's veins drain the blood towards their heart. The blood should only go up the leg towards their heart. And the veins have valves in them. The valves should open up like this when the blood goes through, and then the valve should close. You have superficial veins and deep veins in your leg, and it's the superficial veins, the one that's closest to the skin surface, that usually go bad. What happens is, when the valves go bad in the superficial veins, the blood exits out from the deep vein into the superficial vein and goes downhill in that superficial vein, goes all the way down and causes all the little branches down below to become engorged and form varicose veins. So what we do is we close that abnormal vein that has backwards flow in it. How do we do that? There are many different ways. Traditionally, what they used to do is they would take the patient to the operating room, put the patient to sleep, make an incision about this long in the groin, thread a long metal pin stripper inside the vein to the top of the thigh, and literally rip the vein out of the leg. So obviously the patient had to be put to sleep for that. There was tremendous bruising, there was risk of nerve damage, and there was a high recurrence rate for issues that I don't have time to go into today. So what has happened in recent years is the development of these minimally invasive techniques where the patient's procedure can be done in the office, comfortably. They can be playing on their phone, we can play music in the rooms, and the patients just have an amazing experience. So what do? Well, one thing we do is we put a little numbing medicine, we make a tiny, tiny little nick in the skin, and under ultrasound guidance, we thread a little catheter up the vein to the top of the thigh. Through that catheter, we can deliver energy to close the vein. So we can use a laser to laser the vein shut, or we can use a radio frequency catheter to deliver heat energy to close the vein. So these are the two most common ways, but now we have all these other new exciting things that we're doing. We're injecting foam into the vein, which basically goes up the vein and causes the vein. That was an interesting look I got there. Yes, so
Foam? They're like
putting foam in the vein.
The foam is different.
It's sterile foam, trust me. It's not,
Oh,
it's not,
sterile
it's
foam.
not from my dog.
What is it
Not
made
from
of?
my dog's jowl.
Yeah.
Why is that the first foam you went to?
That's no, we can't talk about that. That's not that kind of foam. So there's also a new technique called VenaSeal, where we can actually deposit tiny drops of adhesive inside the vein, and we inject these little drops. It's like a glue, and we press on the vein seals instantly. We take the catheter out, we put a Band-Aid on, the patient walks out, they can go straight to the beach or the golf course or whatever it is they like to do. They don't have to wear compression stockings, and it's an amazing procedure.
That sounds fantastic. Now, are some of these procedures covered under insurance, or certain ones covered and not covered?
That's a great question, Dr. Boo. Actually, can I call you Dr. Boo?
I am.
Okay.
He plays them on TV and in real life.
Yes.
So traditionally, laser ablation and radio frequency ablation are covered by insurance. VenaSeal is not covered yet. Verathena, which is the foam, is carried in some circumstances. There's actually one other technique which is called mechanical pharmaceutical ablation, or Claravane, which uses a combination of a mechanical irritation of the vein and chemicals to close the vein. So there's a lot of different ways you can do it. That one is covered by insurance as well, subject to the rules of the insurance company. And we all know how interesting that can get.
Oh, well, it's not that kind of show, but I'm sure with all these different options.
That'd be educational. We don't do that here. We're here to entertain.
Right.
Yeah.
Right. So how do you decide what treatments to give patients? Do you actually see the patient before each procedure?
You know, the real truth is, Ken, that it's not a one-size-fit-all world. So we try to take each patient's circumstance into account. It may be that they want to get back on their feet immediately, in which case VenaSeal may be the option. It may be that they're on a budget, in which case laser, which is the most cost-effective, may be an option. It may be that they want to be covered by insurance, they don't want to have too much post-procedural discomfort, they want to have something that maybe doesn't quite have the discomfort that laser can have in some patients, so they may opt for radio frequency ablation. So we decide based upon what's important to the patient.
All right, well, great. So I know there's some questions coming in on veins, and we'll cover at the very end any leftover questions, but I want to turn this over and talk about the arteries now. All right, so peripheral arterial disease is something, it seems like some interventional radiologists are treating, some vascular surgeons are treating. You're one of very, very few interventional radiologists that's treating vascular disease. How were you able to become such an expert and treat this disease state?
Well, you're right. It is kind of a battleground between various different specialties: cardiologists, vascular surgeons, interventional radiologists. How did I become an expert? I started actually also treating veins and noticed that some of my patients also had peripheral vascular disease. And so I started treating that, and I noticed that the results were almost immediate. I mean, you could see a patient with a black toe, you revascularize their artery and automatically like lights up, the color comes back. So, and then it became, when you get results like that, you just go to the referring physician, and it almost became like a no-brainer. I mean, they started sending those patients over and over again. A lot of those patients have a lot of issues. So, and then I went to various courses. This is something that we don't really get taught a lot of in training either. You know, I don't even think vascular surgeons or cardiologists or anybody is really being taught like the newer techniques. When what I'm referring to in the newer techniques is something called atherectomy, where we remove the actual plaque from inside the artery. And my specialty lately has become going below the knee and even going from the foot and going up. So treating the really tiny vessels from the knee down to the foot.
Going safari, are you?
That's right.
So Safari, why don't you tell us what the acronym of Safari stands for? You thought I was trying to make a joke, but this is really a medical term. What is Safari?
I actually don't know what the acronym Safari stands
But I know you come from the
Well, all right, let me tell you guys.
Do it. No.
So Safari was the browser that came after No, that's not.
No,
I
start
think
S
what you're
and go
referring to
through
is a technique for opening CTO. So Safari
Exactly.
is where you go. So CTO is a chronic total occlusion. So some patients with diabetes, long-standing diabetes, they can have their artery blocked from here all the way up to here. Getting across a calcified rock-hard artery that's been closed for 10 or 15 years is really hard. So how do we do it? We go from above, and sometimes, if you can imagine, if we can't get through the rock in the middle, we go into the actual wall of the artery. We're going down, and we're just watching it on x-ray, and we're hoping we're somewhere where we're supposed to be, kind of come, and then we come from the foot, we come up. This sounds barbaric, I know, but the alternative is worse. Come up from the foot, come up, and somewhere in the middle we rendezvous. We kind of poke through the wall, and then we just crush all that plaque against the wall and open up a pathway. So the alternative to that, like Mark said, is surgery where you do a bypass with a graft, bypass the whole thing. Opening up that native artery is a much more elegant.
By the way, we're going to hear that from the
Although it
vascular
doesn't
surgeons.
sound elegant, yeah.
No, they sounded elegant to me. But I wonder, like, Amiel, like the serious side of it, right? Like, number one cause of death in America is heart disease, number two, stroke, right? So that's all like clogged, blocked arteries. So when somebody has an artery that's a problem, right, in their foot, can that lead to a heart attack? And I know some people talk about like this whole thing with dental problems, right? People that have dental problems, like that's often an indicator for other issues, and that could lead to heart attacks. Like, so for you, if somebody has a clogged artery in the foot, I mean, are there real like life and death potential risks to that?
So, yeah, I like how you brought that up. So if somebody has a clogged artery in their foot, sure, they may lose a toe, which is, can be life altering for them. But like you said, the real major risk for them is that they probably also have coronary artery disease. If you have disease in your legs and your foot, like you can imagine, you probably have it around your heart too. So I always recommend those patients be seen by a cardiologist as well and get checked out for any possible cardiac issues. Those are the ones that are going to cause you to pass away, unfortunately. The leg stuff, you're probably not going to pass away from, but it is lifestyle limiting. You can't walk, things like that. You have ulcers, but heart is the more important.
And it's an important indicator, is what you're saying.
It's absolutely
so like that's
indicator. Absolutely.
You
Peripheral arterial disease is a very high indicator of coronary artery disease.
Okay.
Yeah, they're correlated. I mean, it doesn't mean if you have this, it causes this, but they're definitely correlated.
It happened to my grandmother. She went in for an angioplasty and revascularization of her leg, and she had a heart attack, and she died a couple of days later.
Wow. Oh my God!
Yeah.
So yeah, it's real life experience.
Patients are sick. Yeah.
And what are the risk factors people think of when they think of peripheral artery disease, coronary artery disease, and stroke? Are they the same?
I'd say almost 90% of my patients have diabetes, high blood pressure, high cholesterol, smoking. Smoking is definitely a factor, so I counsel all my patients to stop smoking. Whether I'm successful or not, I don't know. They tell me they stop smoking, but it's tough. It's a real addiction. Sedentary lifestyle, so I really encourage my patients, if you get pain after 1 or 2 blocks, I tell them, hey, just go to that 3rd block, just try to go past it. But those are the main risk factors. Diabetes is probably number 1 in my practice.
Well, this is great because we don't normally think of radiologists as physicians that work with patients that have clinic time, but you definitely both are. I know in the interventional oncology world, we certainly have a clinic as well. But moving on to sort of feeling your best, we were talking about some really minimally invasive, even non-invasive approaches to looking better. So what are some of these things that you bring over in your clinic? And what is this? What is sculpture?
Yeah. Sculpture is the new and improved version of what cool sculpting used to be. So what it involves is using an external laser to melt the fat. So we laser. Yeah, so we actually...
Oh, you got to do that every time now.
We put these little applicators on the abdomen or the love handles, and as you can tell, I had it. And you actually turn it on in 25 minutes. It melts 26% of the fat. It takes about 6 to 8 weeks to see your results, and often you need a second treatment to get to the place where you want to be. But it's amazing. You can use it. It's indicated for the abdominal area, but you can actually use it on the underarms. You can use it on the what we call the banana roll, right underneath the bottom, the inner parts of the knees. Banana roll.
Oh, okay.
Can you point to the banana roll?
Yeah, please.
We're
gonna zoom.
Yeah, but we're not going to talk about
We're gonna
foam at the same time that we talk about.
No, just the banana.
Just the
roll.
banana foam.
We just need to see the banana roll.
Yeah.
Yeah,
so,
It's a dance, right?
See the banana roll?
Banana roll. It's like the Cabbage Patch.
It's right here.
Yeah.
I got one. I don't
Let
know.
me see your banana roll.
Right in that area.
Banana roll. I'm just zooming in and out.
That's a good
Zooming
banana
in and out on the banana roll.
Yeah.
I don't know if ratings went up or down.
roll.
So,
We're learning so much today.
so at Beach
Oh, look,
City's
everyone.
Vein and Laser Center, it's natural to take on a laser
There we go.
procedure
There we go.
that melts the
Nope.
fat, and that's exactly what we do. So we do a wide range of aesthetic services. You know, we do some of the other things like Botox and Juvederm and Restylane and all those beautification procedures that make people feel good about themselves.
That's fantastic. Would you say that as a radiologist, knowing the anatomy so well makes you do those cosmetic procedures better also?
I firmly believe that. So, you know, I mean, now there are a lot of people that can do cosmetics, so don't get me wrong. There's a lot of plastic surgeons and dermatologists who do outstanding work, but we're proud of what we do as well, and it's a lot of fun. It's happy medicine, and I enjoy it.
Well, that's fantastic. So, Amiel, fibroids. First of all, what are fibroids, and how did interventional radiologists get involved in the treatment of fibroids?
You're asking me a lot of history, so I'm going to pull up whatever knowledge I know. You can tell me if I'm right or wrong. But so fibroid is basically a benign overgrowth in the uterus. Some people can call it a tumor, but essentially what happens is if it gets to a certain size, it can cause heavy bleeding, a lot of pain during menstruation. You know, a lot of women are suffering from these things. How did interventional radiologists get started with this? I think how it started is that I think Mark is actually probably one of the first people that did it. But what we did is we took pictures of the fibroids, then we, as a pre-operative technique, we would block the blood vessels just so the surgeon would have an easier time physically removing the fibroids to decrease the blood supply. But I think what ended up happening is we blocked these tiny arteries that fed the fibroids, and a lot of these patients weren't showing up to surgery because their symptoms went away.
So previously, if you had symptomatic fibroids, so if you had heavy bleeding, pain, or bulk symptoms, the treatment was what?
Well, there's a few treatments. One of them was myomectomy, where you remove each individual fibroid. The other one is hysterectomy, where you remove the whole uterus. But as you can imagine, that's not a very attractive option for a lot of women.
Right. So uterine artery embolization, where you actually block the arteries that feed the fibroids, that causes them to shrink. And the success rate for bleeding is somewhere upwards between 80 and 90%.
Correct, 85 to 90%.
I've probably done about 500 of these, and these are one of the procedures where when the patients come back, 4 to 6 weeks after the procedure, they're feeling great. It's one of these happy procedures as well. Would you agree?
I agree, 100%.
Well, you've treated a lot of fibroids too, before you just started doing veins, right?
Oh yeah.
What was your experience?
Well, it was an interesting time because when we first started doing it, I was at Kaiser at the time, and we had to fight what we call the IRB. We had to fight this board in order to do the procedure at Kaiser, and we were one of the first hospitals west of the Mississippi to do it. I brought over the chief at UCLA, who eventually became the president of the Society of Interventional Radiology. His name was Dr. Scott Goodwin, and we did the first one at Kaiser together, and then it just took off from there. You can imagine how happy these women are. They no longer have any incisions. You make one tiny little nick in the skin, and you pass a tiny little catheter up into the artery that feeds the uterus, and you inject these microscopic particles. And the uterus shrinks down, and they go home. They walk home the next day, and it changed. It was a game changer. It really was, and it's fun to do as well, right?
Oh,
you love doing it, don't you?
I love doing them. Yeah,
and you're good at them too, aren't you?
Oh, I'm great.
What's fun?
But with that, as technology keeps advancing, right? What are the new breakthroughs that you two see? I don't think 3D printers are going to be what it is, but what do you think the next level of patient care and sort of technology is going to advance to help you guys do more of what you're doing, or do less of what you're doing?
I thought you would know. You were the guy with the white coat in it.
So I would say not specifically for fibroids, but for interventional radiology in general. Like all of our devices are getting smaller. So what I've seen is the shift from hospital-based procedures to outpatient-based procedures. So our procedures are not really, you can do all of them in an outpatient environment. You know, the patient gets discharged the same day. And the reason that is because all these devices I'm talking about, you're removing plaque, all that. So you can imagine that you would think that that's a big device, but they're really tiny. These are like 2 millimeter devices. So we're making a skin nick maybe that big in the patient's groin and treating so many different diseases. So I think that's the next big step. That's the future. The patients are doing it all outpatient. They're going home the same day.
I think I've noticed that really has been a huge shift in interventional radiology is the development of interventional oncology. The ability to thread a little catheter to a tumor in the liver or in the lungs or in the kidneys or God knows where else and deliver chemotherapy is a game changer. And I think that that's one of the reasons why we're here today. Because we want to be able to take the cure of cancer to the next level. And every day people are working hard at it to try to find out what can we do next to make it so that we don't have to deal with these issues anymore.
Yeah, interventional radiology is actually playing a big role, really the fourth pillar in the treatment of cancer. You have your medical oncologist, you have your surgical oncologist, your radiation oncologist, and now your interventional oncologists, which are your interventional radiologists that are using interventional techniques to treat cancer with minimally invasive procedures. I know we have a lot of questions coming in, but our show is running short, running long, so we have to wrap up.
One person's long is one's short. Yeah.
So it's always about size with these. So, how do patients come out and find you then? I mean, so Mark, your practice, how do people find out about your center and come to you?
That's a great question. The internet. They read our reviews online. I think that in our practice, we leave no stone unturned. So everything we do, we try to do to the very highest level, you know, from how that patient is treated when they walk in the door to when they leave, you know. And so because of that, and because we care about their comfort and their cosmetic results and their entire experience, our reviews online are off the charts. And so that's why they come to us from the internet. Yeah.
Also foam parties.
And phone parties too, yes.
Phone parties.
Okay, so on the internet, what is the name of the website that they go to?
They go to beachveins.com or manhattanbeachveincenter.com.
Okay, do you happen to have a Facebook or Instagram handle? Or
We do, and Dee knows that better than I do.
Dee, what is it?
We are on Instagram at Mark Rayman MD.
Mark Rayman MD!
All right. On Instagram.
And Facebook,
Wait, do that
you
again.
can find us under Beach Cities Vein, I believe.
Oh, the lovely Drs Rayman.
City's Vein.
All right.
Facebook. All right.
And Amiel, what's the name of your clinic again in Beverly Hills?
Pro Health Advanced Interventional.
Okay, so how do they find you online?
Look at him. Tell him.
Prointerventional.com.
Oh shit.
Whoa,
He had the point too.
All
What?
right.
What I love
Slate
is-
your name and your height.
He didn't even say www.https// Like he's like, no.
Don't even need the W's for that one.
You know it. He called somebody out in the audience. You know, it's place. So, I mean, thank you both. I mean, I really want to say, like, you know, and before I met Kien, I knew nothing about interventional radiology. I've probably learned less since I met But talking to you two, I actually think there's some good doctors in this field. No, but I'm excited because I know, you know, Kien with Live Again Project, the whole thing's, you know, taking it to getting cancer survivors and cancer patient stories. And what you guys are doing is really important work. And I think even, you know, whether it's cosmetic, whether it isn't, it's still like, you know, you're changing people's lives. And you're really the first people that some people open up to talk about with these really important issues. And it leads to obviously a lot of problems if they don't see people like you guys. So thanks for coming on the
Thanks
show.
for your
Thanks
work.
for what you're doing.
The show would not be complete. This show is looking and feeling your best in 2017. We've learned about how to do that from a medical perspective, but how do you do that from, you know, a spiritual or personal perspective? So I want to introduce a future guest. She's going to be on a panel in Behind the White Coat in the future. We have the lovely Dr. Natacha Telusca. She is a pain medicine specialist. and has her own wellness center. Natasha, welcome.
Take my seat. For you guys, I wouldn't even
Oh,
have my
right.
seat.
No, she's just going to stand up right here.
No.
No, you want to stand? All right. So,
Sit and get comfortable here.
oh, I'm going to get comfortable too.
Wait a second. This show just
This
changed.
feels great. Looking and feeling
Do we
like
have a
best
back
here.
replacement? That looks
It's an upgrade. It's an
Yeah.
upgrade. It's an
Well,
upgrade.
welcome everyone. Thank you so much, Dr.
Oh, of
for
course.
having me. It's
She's
a pleasure
hosting.
to be here.
All right,
And,
you're kicking off our show, or like finishing up this show. How do people look and feel their best in 2017? You got 6 keys.
That's exactly correct. I'm a pain management specialist. I also do wellness coaching. So when I see patients, I always, if time allows, share 6 things with them to improve their quality of life. The number one thing is lower your stress level. America is everywhere, the world. We are so stressful. So many things are bombarding our lives. One thing I teach my patient is try to minimize and lower the number of stressors in your life. We all know that stress can cause heart disease, diabetes, and anxiety, depression, and multiple other diseases. So I try to encourage my patient to live in the present. When I was a med student, I realized that I live in the future because I see life as a destination. There was this next thing. So I didn't take time to enjoy the present moment because I wanted to get to the next thing. After I finished med school residency and got a job, I realized that there is no next thing. I have this job. I don't have anything next to look forward
always
to.
right here, isn't it?
Exactly.
It's always right now.
Exactly.
Right?
So I'm learning to stay in the present, and that tends to lower my stress level.
All right.
Because if I don't focus in the future, which may never comes, then I stay here in the present, then that allowed me to live life to the fullest.
That is such an important point of so many cancer patients that I know start to just really live in the present, and that's changed the way they've approached life. So what's number 2?
Number 2 is physical exercise. It's exercise, physical activities. For me, I encourage my patients to try to do about 5 days a week, 30 to 45 minutes a day. I don't care what you do, just move. For me, I'm a big CrossFit and Pilates girl, so I do Pilates and CrossFit.
Can you
But-
show Kien some things?
That's the next show.
That's the next show.
What's number 3?
Number 3 is your diet. And I don't like the word diet because I've tried so many diets in the past, low carbs, high protein. Diet doesn't work in the long term. It's good for short-term weight loss and weight maintenance, but it's very hard to keep up a low carbs or high protein diet. So I encourage healthy eatings. For me, I try to eat 5 days a week of balanced, healthy meals, and I cheat on the weekends. One day, on Fridays, I'll allow myself to have whatever I want to eat. The other 5 to 6 days, I follow, very good eating healthy habits. So that's the
3rd one. Okay.
third one.
4th one. So we got lower your stress levels, be present, your diet, and 4th.
Exercise.
Exercise. Oh, we'll be
present.
No, we're in 4.
No, it's 4. You
Four.
made 1 into 5.
They're doctors, they're not mathematicians.
Yeah. Doctor needs
Just 'cause I'm
4
patient.
cc's of this?
Yeah.
Can't count.
Or
Number
5.
4 is relationships. We became so isolated. I found myself when I moved to LA, I'm from a big family, I'm one of 10 children. I moved to LA and I find myself very isolated because you go to work 10, 12 hours, and you come home and you face the walls. So I encourage my patients to build relationships, whether it be spiritual relationships, romantic relationships, friends, family. Do something. Call people. Build your support system. Find your tribe. We were not meant to travel this journey alone. So I tell my patient, either go to meetup.com, wherever you can find people, get your tribe going. That's number 4.
That's 4?
Yes.
Number 5.
Oh, what's the number
Wait,
5?
wait, number
That was 5.
No, that was number 4.
That was 5.
No, that's 4.
That's 4.
Why do you have 2 fingers up?
That's 4.
So number 5 next.
Number 5 is sleep.
Oh, okay, it is number 5.
Sleep, you cannot make up for lost sleep, people.
No.
You cannot spend 5 days a week sleeping 4 to 5 hours a day and expect to catch up on the weekends. Doesn't do you any good. So I highly encourage, catch up whenever you can catch up, 2 months later or whatever. Lost sleep is lost sleep. You don't make up for it later on.
What do you recommend?
I say 7 to 8 hours a night.
Okay.
That's my recommendation.
7 to 8 hours.
So good sleep. Number 6.
6.
You all can use your imagination on number 6.
What's number 6?
Use your imagination.
Why is there giggling in the background? Do I not know what number 6 is?
Random
She
fingers.
put up 5 fingers for number 6.
4, and then put 6.
See, that messed up my camera.
Number 6.
You know what? You got our producers. The show's canceled. We're done. I don't know anymore.
Number 6.
There we go.
All right, wait, let's review the 5 again. All right?
No.
Let's get up 5.
Can we first practice counting?
Let's review numbers.
We're gonna go review the
From
5.
number 1, low stress level.
Low stress.
Physical activities.
Okay.
I'm forgetting the third one.
Diet.
Diet.
Diet. That's not diet.
Relationships.
Relationships. Exercise.
Exercise.
What's number 6?
Number 6, you all
It
don't
sounds like
laugh.
6.
Don't laugh. But I think great sex.
Wow.
If you can have it.
That's not number
please
1.
do.
How's that 6 and not 1?
Because
How-
not everyone can.
how's that
have
at the first
sex,
one?
So
Why is
because-
that?
You know what? This order, you can turn it
Hold on.
around.
Wait,
Wait a
not
second,
everyone
I
can
don't-
I
have
know
sex?
why. I know why. Because if you do the other ones, then you're more likely to be in positions where you can have great sex.
Yeah.
Thank you very
There we go.
much.
And you'll be hot.
Can't.
Wait a second.
What? Wait, positions?
Thank
Well,
you.
positions.
Thank you very much.
Why does this show have to go that way?
I know.
I'm trying to put on a legit medical show
Yeah,
here.
you told us it literally starts there.
Wait. Is it great sex or just sex? Because I need to figure this out.
I say great sex.
Okay.
One person's just great.
Yeah.
Do they
I'm
have to-
sorry you're bad for my
They have to
health.
pay for the treatment as well. If they...
You have to watch
That's
my
another
show to
show.
get that answer.
All right. Well,
Whoa.
great having you. Once again, the six things:
Low stress.
low stress,
Exercise.
exercise,
Diet.
diet,
Relationships.
relationships,
Sleep.
sleep, and sex. All right. Well, we want to thank Dr. Natacha Telusca.
Where can we find her?
You can find me
Oh,
at
that's right.
TeluscaHealth.com. Telusca.
Ooh. Look at that fancy.
TeluscaHealth.com.
That's me.
Dr. Natacha Telusca at TeluscaHealth.com. We've got Dr. Amiel Moshfegh from Interventional.com. And we've got Dr. Mark Rayman from Manhattan Beach Vein Center.
.com.
.com. All right, that is it for our show. Next week is Valentine's, and we meet together again on March 21st. I want to bring up our special guest, Brina. Come on up, Brina.
Ken, why is no one wearing shoes?
That's his
Asian house.
Because it says... Because we're in your house.
And we've got Nixie. Where's Nixie?
I'm over here.
She's going to be coming in. Again, we want to thank everybody on the show. And now, this is our opportunity to take the cameras from you guys and thank all of our volunteers every week. We got comedian Adam Dubowski. Magic Mike Moore. Laurel Brewer on the ones and twos. Diddy Rayman. Say hi, Diddy.
And Alexia.
Kate. The lovely Star Lee, and show producer Alexia Anastasio. Every BO doing it, Sydney. Sydney, he is our key camera guy. He's going to be actually hosting one of our shows in the future. Ladies and gentlemen, thanks for coming to episode 3. We will see you February 21st. Bye-bye. Good night.
All right.